Thank you very much for coming today. Again, I'm a pain management specialist. I started about 10 years ago, and when I talked to the other doctors, they didn't even know who is a pain management specialist. So I have done it so many times, trying to educate the people and even the other doctors also. And it's a very casual kind of presentation. Feel free to interrupt me anytime. I got plenty of time to answer any questions you guys have. So I'm fellowship trained in pain management. Fellowship training is becoming a standard of care these days, more and more often. I'm board certified in pain management. So my practice scope is the most common patients I see is low back pain, neck pain, headaches, radiculopathy like sciatica, pain going down the leg or in the arms, arthritis in the neck and the lower back, neuropathy. I see a lot of patients who have had back surgeries done still have pain, phantom limb pain. I see a lot of patients with post-herpetic neuralgia, which is fancy name for post-shingles pain, RSD or CRPS, and any other chronic pain, headaches, neck pain, low back pain, sometimes chronic abdominal pain. Everyone can hear me pretty good? Okay, that's good. Okay, so my goal today is talk about increased knowledge of chronic pain, talking about various causes of chronic low back pain, and then answer any questions you guys have. So we are talking about low back pain because it's the leading cause of disability in men under the age of 45. 1% of US population is chronically disabled due to low back pain. And we spend about $90 billion on low back pain per year, which is 3 times more than cardiac services. It's again, the expenses are so high on low back pain. A study was done where they asked a survey, where they asked people, does your back feels young? That was the question. 1/3 patients said no at age 30. That number went to 75% at age 40. So anyone who lives up to the age of 50 can have some limitation due to low back pain. Another study was done which showed, it was done in workman's comp patients, which showed people who were out of work for 2 years, 1 year, and 6 months, and their chances of going back to work. You can see their chance of going back to work was 40% if they were out of work for 6 months. That chance go close to zero if they were out of work for 2 years. So this shows the significance to treat the low back pain as soon as possible. The longer you wait, the less results the treatments have. So I like to ask this question to the audience usually. I see a lot of patients who said, what the heck, I have low back pain, I can live with this. I'm not having any effect from that. So I like to ask this question, chronic pain has no impact on my body. True or false? So this is false because we know, even without our knowing, chronic pain can cause significant impact on our body. It can cause decrease in breathing, can cause nausea, can cause vomiting, can cause muscle spasms, can cause anxiety, depression, increase in heart rate, even without knowing that. I saw one patient last week where the pain went down and his blood pressure went down because he was taking blood pressure medications, and pain was increasing his blood pressure. Pain went down, there was no need of blood pressure medication in that particular patient. So without knowing, his blood pressure was high because of that chronic low back pain. Before we talk about the causes, I want you to talk about the anatomy of low back pain. So this is the low back vertebra, disc, in between each vertebra, spinous process, spinal cord runs like this, nerve coming out on each side, and the joint on each side called facet joint. So again, disc, spinal cord, nerve, and the joints. So any of these structures can cause low back pain. Disc can do that, nerve can do that, arthritis or the joints can do that. So this is the same slide. Again, the herniated disc or bulging disc causing pressure on the nerve. Arthritis or facet joint disease can do it. Sacroiliac joint can do it. Misalignment like scoliosis can do it. Or compression fracture can do the low back pain. Every patient or most of the patients I see are going to have superficial muscle problems along with these problems. So an underlying disc issue, underlying joint issues can cause superficial muscle spasms. Until and unless you fix the underlying problem, those superficial muscles are not going to get better. Depending upon where the pain is, whether it's only low back pain or the pain going down the leg or legs, we can, to a certain extent, tell what may be causing the pain. If it's only low back pain, the disc may be causing the pain. So we are talking about this slide because when I see a patient, my aim is to try to make a diagnosis. If I know what's causing the pain, I can treat that patient more efficient or efficiently. So whenever I see a patient, my aim is to try to make a diagnosis. And I can't stress it anymore. I see a lot of patients from sometimes different doctors, radiologists, where they are working on different diagnoses. Again, when I see a patient, if I can make a diagnosis, I can target my treatment in that particular direction. And the treatment is effective also. So again, when the pain is only in the low back, the joints can do it, the disc can do it, or the compression fracture can do that. When the pain is going down the leg or legs, the disc herniation causing pressure on the nerve can do that. Spinal stenosis can do that. So what is spinal stenosis is, when you stand and walk, pain comes back. When you sit down, pain goes away. You stand and walk again, pain comes back. You sit down, pain goes away. I see hundreds of elderly people with this kind of problem. If you go to a grocery store, you can see a lot of people scooching over the grocery cart. They all have spinal stenosis. This is one of the most common problems I see. So it's also called neurogenic claudication. After surgery, there can be scarring causing pressure on the nerve, which can cause pain in the leg. So I'm going to skip a few slides. Same thing with the neck. Whiplash injury or arthritis can cause the headaches along with the neck pain. And of course, the disc disease can do that. So again, we are still trying to make a diagnosis. Other things which can help to make a diagnosis is X-rays, MRI, CT scans, discography. So when I see a patient, my aim is to do a good examination with history and have a diagnostic imaging to make a diagnosis. Because once the diagnosis is made, like if it's the disc which is causing pain, joints causing pain, nerve causing pain, then we target our treatment in that particular direction. Sometimes I see a patient, I ask them, where does it hurt? They say my L3 hurts, because that's what my MRI shows. A number of studies has been done where they took, in this particular study, they took 67 asymptomatic people, no back pain, did MRI on all of them. Up to 93% of those patients showed a bulging disc without any symptoms. So a herniating or bulging disc in itself doesn't tell pain is coming from that area. A good examination is needed to match with that MRI to make a diagnosis. So same thing. I like to show this slide usually, what can people do to hurt themselves. I think the volume is not there, I guess. Here we go. Again, my aim is whenever I see a patient is try to make a diagnosis, because we can treat that patient efficiently if we know what the diagnosis is. You're gonna be kidding, your back still hurts? Okay. So I'm gonna skip these slides, but who's a pain management specialist? As I mentioned, it's a specialized training these days to treat patients who has chronic back pain or chronic pain. And we are worried about patients' ability to function and improving quality of life, and also reducing pain, of course. And also, as I mentioned, fellowship training is becoming a standard in pain management these days. So my aim is try to avoid surgery and heavy medications and reduce the pain on the same token. Okay, so our management goals, same thing, make a diagnosis, try to reduce the pain, improve function and quality of life. There are some prevention steps which can be done while driving. Adjust seats so that the hips and knees are in level. Do not overreach for pedal. Proper body ergonomics. Stand with good posture. Lift heavy objects by bending at knees and use firm mattress. So regular exercise, of course, and proper posturing while sitting also. That helps too.
I have a question. A lot of the, you said to have a firm mattress, and a lot of the mattresses now have that foam, what do they call that foam?
It's called memory foam.
Memory foam. So how's the memory foam compared to just a plain firm mattress?
Okay, so the question is, I mentioned using a firm mattress. Lot of mattresses are having memory foam. Which one is better, firm mattress or memory foam? Research, again, my understanding is using a firm mattress is better than using a memory foam mattress. Even though a lot of mattresses are having a small portion of memory foam inside every mattress, but try to go for as firm as possible. Okay. So again, if someone has low back pain, we can start with simple things first. Over-the-counter medications. Over-the-counter medications, physical therapy, manipulation, tense unit, muscle relaxants. If that is not working, comes the role for more aggressive approach like epidural injections or facet joint injections. That's what I do the most. If that's not working, comes the role for surgical options or narcotic medications for long term.
So how often do you give injections?
Okay, let's talk about that. So that's coming up. Okay, so next is injection therapy. As I mentioned, that's what I do the most. The very commonly done injection is epidural steroid injection. I'm pretty sure everyone must have heard about that injection. The indications is mostly used in spinal stenosis. If you remember, we talk about spinal stenosis is the pain when you stand and walk, pain comes back. When you sit down, pain goes away. So that's one of the indications for this kind of injection. Other indication is sciatica, where there's a disc herniation causing pressure on the nerve. Another indication can be degeneration of the disc and spinal stenosis. So before we go to any other kind of injection, epidural is a very commonly used word. These days, we are doing something called transforaminal epidural as compared to interlaminar. And the difference is In interlaminar, you go right in the middle and inject the medication. You cannot control if the medication is going left, right, up, down. Lot of the newer doctors are doing something called transforaminal epidural. Research has shown transforaminal is more effective, and you cannot do transforaminal without a fluoroscope or X-ray machine. In transforaminal, you can go left, right, and you can go around that particular nerve which is causing the pain. When you hear the word epidural, look into if it's interlaminar or transforaminal. Again, transforaminal research has shown is more effective than interlaminar.
Is there any side effects from those injections?
Let's talk about that also. Okay. So as I mentioned, first of all, it cannot be done without an X-ray machine. Neo doctors are doing transforaminal, can be done in neck, thoracic, and lumbar. A lot of patients ask me if they're addicting. They're not addicting, and they last between 3 to 6 months. So you need to repeat it every 3 to 6 months, but our body tend to do the healing of that herniating disc. So if the injection can give that time frame, there is a chance our body will do the healing of that area, if that makes sense. So again, our body tend to do the healing of that area. They are not addicting. If you do it under X-ray machine or fluoroscope, the risk is very, very low. Some patients ask me about the overdose of cortisone or steroids. If you are doing up to 4 to 5 injections in 1 year, and each time 1 cc of cortisone is injected, there has been no side effects of cortisone also. If you have like 10 injections in a year, yes, you're going to have the overdose of medication. Insurance companies are not paying, to my knowledge, more than 6 injections of these in 1 year.
3.
So again, they pay 3 in 6 months. So again, I'm going to say it again, they pay 6 in 1 year, and I'm positive about that. Okay.
I've had that done, and all it did was make it hurt worse. And I had it under with fluoroscopy.
Okay, so the question is, someone had this injection done, and it made it hurt worse. So that comes back to the same question of making the diagnosis, whether it's really the disc herniation causing pressure on the nerve, or if it's the facet joints, or if it's only muscle. So if there is a right diagnosis, it should not hurt more after the injection. Yes, it can cause soreness of the muscles, but it should not hurt more. If it is hurting more, we need to relook into the diagnosis, if we are at the right diagnosis. I'm going to give you an example here also. There has been a few patients where the MRI shows L3 nerve root problem, and they had the L3 injection done, even though when you examine them, they have L5 nerve root problem. So whenever I see a patient, I tell them, I'm not treating MRI, I'm treating you guys, your problem is at L5. If MRI is showing L3, I shouldn't go after L3. I need to go after your symptoms rather than treating the MRI. So we need to relook into the diagnosis again. You have a question?
What does this stuff do? Does it numb it?
Okay, so the question is, how does the injections work? You need inflammation or swelling to have pain. Whenever there is a disc herniation causing pressure on the nerve, it's not going to cause pain until and unless there is a swelling or inflammation. So research has shown these injections tend to reduce that swelling or inflammation in that area. There has been a couple studies which has shown that whenever there is a herniating disc or herniated disc, it releases some chemicals. And there has been a hypothesis that these injections or the medication can neutralize those chemicals. And I tell my patients that it can give a platform to your body so that your body can do the healing process. So injections are not going to do the healing, it's our body who is going to do the healing. So it can give a platform to your body so that it can heal. Also, physical therapy or activity has shown to have that healing process faster or better. If your pain goes down, you can do physical therapy better. Lot of my patients, if they are in pain, they said, I can't do physical therapy because I'm in pain. So aim of reducing that pain is so that they can go to physical therapy, they can go to chiropractor, they can walk, so that the healing can happen. If there is enough pain that you're not getting out of your bed or out of your home, things are gonna keep on getting downhill. Aim is again to make you physically better so that you can be outdoor, improving your quality of life. I have a patient who tells me that I want to play golf, and whenever I have that twisting motion, it hurts. So he comes every 3 months, get the injection done so that pain goes down and he can play golf. For him, playing golf is improving quality of life. Yes.
So if you have an injection and the pain is, for instance, my husband has bone on bone, and they've injected it about two or three times. So what's the course of action here? We're talking about knee replacement, or are we going to keep doing injections, or?
So you're talking about the knee, right?
It's a knee.
Okay. So the question is, if it's bone on knee, what can be done? If it's bone on knee, I think the final treatment is to have a knee replacement done. And injections are buying you time so that first of all, you have the time before you have the replacement done. And usually injections, again, you're buying time to have that done. That's the most common scenario. With the knee, with the back, it's a whole lot different story. And I want to talk about that also, because if it's joints in the back which is causing the pain, we can do something to deaden the nerve, which can help for about 18 months. So let's spend 2 minutes on that before we take any more questions. So again, the kind of injections which are done, the very commonly done is called epidural steroid injection. The second most common injection which is done is called facet joint injections. If you remember, these are the joints, one on each side. And I see some patients who can get arthritis, can get whiplash injury in the neck, and research has shown that that can cause micro trauma to the facet joints. Patients start to have headaches along with the neck pain. So the injection which can be done in the facet joints, if pain goes away, there is something else which can be done called radio frequency ablation, fancy name, where you go in and deaden or burn the sensory innervation to that joint, which means the nerve which carries the pain to that joint can be deadened. Our body regenerate or regrow the nerve. Takes 9 months to 18 months to do that. So that gives you pain free for 9 months to 18 months, let's say 1 year, so that you can do physical therapy and mobilization of those joints so that pain may not come back. But if pain comes back, then you can have this procedure done again after 1 year, called radio frequency ablation. So again, arthritis in the back, in the joints, can be helped longer period of time with this procedure as compared to knee pain or knee joint pain. Okay, so
I'm fused already, but
Okay.
having new symptoms from the same area where I'm fused,
Okay.
so, and I've had everything but ablation done, is that something that would be feasible for that?
okay, so the question is, if you have symptoms after a spinal fusion, the problem with the fusions are, research has shown you're going to have whenever something is fused, the joints above and below has to move more to compensate for that fusion. I see a lot of patients, they start to have problems above and below the fusion. And sometimes scarring or fibrous tissue at the level of fusion can cause pain also. So to answer this question, you need to find out what's causing the pain. If it's the joints above and below the fusion, or if it's the scarring at the level of the fusion.
They're saying it's the same.
Is-
I'm L4 to S1 fused, and the symptoms are there. I am having breakdown in 3-4 and 1-2, or 2-3.
Okay.
So that is happening.
So if it's, again, the same question, if the problem is coming from the facet joints above the fusion, yes, a facet joint injection can be done. If it's a different problem, a disc issue or spondylolithiasis, where there's a movement of the vertebra, that's a whole lot different kind of treatment. We will talk about spinal cord stimulator also. In some patients, after the fusion, there can be scarring tissue or fibrous tissue on the nerve, and there is a different kind of treatment for that problem. So I can go through that also. Okay. So a research was done coming back to the epidural injections, where 57 patients were sent to spine surgeons to have the surgery done. I'm going to step back actually. Whenever I see a patient, my aim is try to avoid surgery as much as long as possible. That's what I'm trying to achieve. A number of studies has shown that doing these injections, patients can avoid surgery for a long period of time. So this is one of the surgeries which was published in 2000. This was done by spine surgeons. So a family doctors send the patients to have surgery done to spine surgeons. Rather than doing the surgery, they randomized controlled these patients. Half of those patients got an injection and the other half got a sham injection. So 71% of patients who had injection done decided not to have surgery. And they followed those patients up to 5 years. Again, 71% of those patients decided not to have surgery done after having the epidural injections. And as I mentioned, number of studies has shown that. That's one of the other studies. Yes.
What about a type of steroid? I have osteoarthritis in my shoulder, and they did an injection, and it didn't work, and so they put me on a steroid regimen. It was like a week long, like 6 pills, and then 5, and then 4.
So the question is, what's better, having an injection done or taking the steroids by mouth? What I tell my patients is, I'm not a big fan of oral or by mouth steroids, because that's going to your whole body the 100%. When I do a spine injection, only a very small amount of that goes into your system. Most of that is working right where it's supposed to be. So again,
The shot didn't work, so then they did that instead.
again, depending upon where the injection is done, if it's done in spine, arthritis, we can do radio frequency ablation. If it's the other joints, let's say knee, shoulder, then again, then you're stuck with having that buying out time and having the surgery done or those kind of things, if that's needed.
What do you know about Tarlov cysts?
Again, not much, but again, the question is about Tarlov cyst. What can be done? The problem with any kind of cyst is once you drain it, it can reoccur. So usually you have to get it removed if it's causing the problems. A lot of cysts may not cause the problems, but if it does, it needs to be removed, otherwise it's going to keep on reoccurring. I have done some aspirations, but again, there's a chance it may reoccur again. Okay, so I'm going to skip these slides. Again, the facet joint injection, we talk about this. The only way to find out if you have facet joint pain is to do an injection in the facet joints, and pain goes away, tells us yes, pain is coming from the facet joints. There is no other test to find out exactly if pain is coming from the facet joints. Now skip this slide. And I have done a lumbar sympathetic injection also, which is done in post-herpetic neuralgia, which means post-shingles pain. I see a lot of patients who have this pain, and they tell me it's such a terrible pain that nothing works. In those patients, the sympathetic injection sometimes has shown results also. It's called stealth ganglion injection in the neck. I have done that in phantom limb pain or vascular insufficiency also. Are you gonna whine or are you gonna let me fix your back? So lastly, I want to talk about spinal cord stimulator. It's mostly used in people who have had surgery done, have injections done, nothing is working. And I know a lot of patients have tried that. They have fusion done, it's not working at the same level. They have injections done, that's not working. So if pain is coming from the nerve at the same level the surgery has had or had been, then a spinal cord stimulator may be able to help. It's an aggressive approach, usually done in the end when everything else fails. So the good thing about this is you can test drive it. There are leads which are implanted in the epidural space like an injection. You go home for 5 days and test drive it. If you like or helping you with the pain, then a surgeon has to implant this underneath your skin. So again, it's a more aggressive approach than a simple thing. If it doesn't work for you, it's not for you.
I've had one of those, but I had to have it removed. Is there anything beyond that?
Okay, so the question is, let's say this is not working also. What else can be done? So depending upon the location of the pain, the other options can be medications by mouth or something else called morphine pump. That's like the last resort you can go kind of thing. So again, morphine pump is the next step, or medications by mouth.
So ablation afterwards wouldn't work?
Usually, again, the question is, will the ablation work? You should have done that before you get to this step. This is a last resort kind of thing. You should try the simple injections first before you get to this. If an ablation is working or a epidural is working, you're not supposed to go to this. It's an expensive option.
I've had 2 and they've both been removed.
All right, so again, it's an expensive
That's why I'm
option.
wondering about the ablation, because that's a whole.
Right, so again, that should have tried first. And if this is not working, comes the role for pump or oral medications.
Yeah, oral medications aren't doing any good.
And as you mentioned, then pump may be one of the options, depending upon where the pain is. Okay, so in summary, transfemoral epidural for set joint injections. If this works, comes the role for radiofrequency ablation. Joint injections like HIP or SI may need spinal cord stimulator if everything fails, especially in post-surgical patients. Mr. Osborne, may be excused, my brain is full. Thank you very much for coming today. Thank you. And I get plenty of time. If someone has any other questions, I'm here. Thank you.